Good afternoon. Thank you, everyone, for coming. So today they've asked me to speak about the revival of the loop. My disclosures here for intuitive. So the objective of this talk is to talk specifically about benefits and limitations of a loop configuration versus a Y configuration. We are focusing on OAGB in this particular section, but more in general. So we have on the left-hand side our traditional Roux-en-Y reconstruction. You're looking at a smaller gastric pouch with 2 anastomoses. And then on the right-hand side are loop anastomosis, or the OAGB, with a longer gastric pouch, and pictured here a side-to-side, but also described as an end-to-side anastomosis. So in 7 very quick minutes, we're going to talk about technical considerations, long-term complications, efficiency, and outcomes. So technical considerations, when we're looking at a 1 anastomosis versus a Roux-Y reconstruction, we're looking at a single potentially versus a multi-quadrant surgery, depending on your technique, 1 versus 2 anastomoses, and mesenteric defect closures, 1 versus 2 or 3, depending on how you do your gastric bypass. This can translate potentially into reduced surgical time, perhaps a less technically adept assistant bedside, and that can, of course, save time as well. So looking at the literature, looking at Lee et al., 2012, looked at 10 years ending in 2010 in over 1,600 patients, concluded that a Roux-Y gastric bypass has similar efficacy over 1 and 2 year follow-up for weight loss. Mean operative times were shorter for a 1 anastomosis, which makes sense. Early postoperative complications were higher and statistically significant in a gastric bypass, including leak and bleeding. However, long-term complications between the 2 procedures were similar. So we're going to focus specifically on the complications that we all talk about with a Roux-en-Y: internal hernia, marginal ulcer, intussusception, and bile reflux. So looking at this study, which was a systematic review, meta-analysis of 6 studies, showed overall no significant difference in complications of leak, bleeding, or marginal ulceration. They did show higher rates of reflux in OAGB patients. However, it was not statistically significant. So then we move on to the study in 2022. This was a single-blind, randomized controlled trial. Overall, they saw no statistical significant difference in leak, internal hernia, marginal ulceration, or bile reflux. However, they did see similar long-term weight loss. Initially, in the first 6 months, they did see faster weight loss, which is in pink there, with the OAGB. However, it did normalize, equilibrate at 2 years. So then looking at a prospective cohort study in 612 patients, we're looking at late complications here. So reflux and malnutrition were higher in the OAGB group, but they were not statistically significant. Internal hernias and marginal ulceration were higher in the gastric bypass group, but they were also not statistically significant. We are getting closer to statistical significance on internal hernia, and I think as we see larger studies, we probably will see that separate itself. However, we did see higher dumping with a gastric bypass. The Y-omega trial, I chose specifically to focus on esophagitis from this trial, as this is kind of a hotter topic. When you look at OAGB versus Roux-Y gastric bypass, OAGB did show higher rates of esophagitis on endoscopy. However, when they looked at the grades of esophagitis, the majority of those were grade A, and therefore they concluded that this was not clinically significant esophagitis. Therefore, OAGB was not worse than gastric bypass in that category. So intussusception, obviously we don't have data that's going to compare the two without a jejunal anastomosis. And this is a very rare complication of gastric bypass, 0.1 to 0.3%. But I can speak for myself and for everyone in the room who has taken a patient with intussusception back to the operating room. It's a terrible operation. We're probably doing an open operation. So if we can avoid this, this could be beneficial in the long run. So conclusions, I can say that the loop reconstruction may be more efficient. Their outcomes may be similar, and the complications are no worse than a Roux-en-Y gastric bypass. Thank you.